to introduce the next speaker, which is Robert Jan de Vos. It's a sport physician, and he wrote a thesis on the Achilles tendinopathy, and he's going to share his insights on this. Robert.
Okay, can everyone hear me at the back as well? Yeah, all right. Well, thanks for the introduction, and thanks for inviting me to this Congress. I'm more than happy to display some of the results from my thesis, and I will mainly focus on the imaging part today. I'd like to declare that I don't have any conflicts of interest. And I'd like to take the opportunity to introduce myself a bit more. In 2010, I finished my thesis on imaging and treatment of chronic midportion Achilles tendinopathy. You can find the whole thesis on this website, so if you would be interested, you can download it for free. After that, I finished my residency in sports medicine, and I did a clinical fellowship in the Aspetar Sports Medicine Hospital in Qatar. And I'm currently working as a postdoc researcher in the Erasmus Medical Centre in Rotterdam. I'm mainly focusing on developing new treatment options for chronic tendon injuries. And I'm also working as a sports physician in the Sports Medical Centre in Maastad, which is near to Rotterdam. And I'm also working as a club doctor for Excelsior Football Club. So now about the topic of this presentation, tendons. Tendons are hot, and we know it because of the superficial digital flexor tendon of horses after running, which can, in which the temperature can rise up to 45 degrees after running. But we also know it from the number of publications in the recent decades, which increased exponentially. So the tendons gained a lot of attention the last years. So I'd like to start with my take-home messages for didactical reasons. Ultrasonography appearance is abnormal in chronic Achilles tendons. Chronic painful Achilles tendons. Ultrasonography can visualize the changes over time, but there's no association between the abnormalities and pain, and there's no prognostic value of the ultrasonographic abnormalities. And of course I will present data why I came to these conclusions, and at some points it will be a little bit academic, and I think it will be really interesting because I will show some new ultrasonographic techniques, and perhaps you will become familiar with it, and it will be used more and more in the future, I think. And I will try to explain it as simple as possible. And of course I will also translate it into clinical practice. So the focus for this presentation is the patient with long-standing symptoms, more than 2 months, and the mid-portion area of the Achilles tendon, which is located at 2 to 7 centimeter proximal to the distal insertion. It's normally there's isolated pathology there. So there's no concomitant pathology from a bursitis or bony pathology, which makes it ideal for research purposes. Something about the biomechanics of the Achilles. The Achilles tendon is acting as a coil, so during landing energy is stored, and during the push-off there's a release of energy. And already 2 decades ago there were in vivo measurements of the Achilles tendon, and the researchers showed that the Achilles tendon is subjected to loads up to 2.5 times the body weight during walking, and up to 12.5 times the body weight during running. So running is really demanding for the Achilles tendon. Something about histology, which is important as well. Normal tendons are arranged in hierarchical fashion, so from the collagen molecule to the whole tendon body. And if we would take a biopsy of the Achilles tendon, you can see this image after staining, so this colored image. And here you can see the main constitute of the extracellular matrix, which is collagen type 1 in the tendons, which is the purple color here. It's all the collagen fibers are directed in one are aligned in one direction, in the direction of the tensile forces. In between, you can see small flat tendon cells, which are the tenocytes. And the tenocytes are responsible for the production of the extracellular matrix. So I'll come back to that later, what happens when something goes wrong there. Then to the patients, which we see in the clinical practice. We know that tendon injuries are associated with overuse and aging. And in case of pain and swelling in the midportion area and an impaired performance, we can establish the clinical diagnosis of tendinopathy, which does not need to be confirmed by imaging or biopsies. So it's a clinical diagnosis. We know that these patients with chronic painful symptoms have histological abnormalities, and I will show you. Again, here in the upper picture, a normal histological image of an Achilles tendon. So the collagen fibers are running in one direction, and with the arrows, the small tenocytes, which have a flat appearance. In the bottom pictures, you can see the abnormalities. And this is an image of a biopsy from a patient with tendinopathy, and it's obvious that the tendon structure has decreased. So it has a wavy appearance, and there's no clear alignment in one direction. Another feature is the cellular change. So we see a lot more tendon cells, and they also have a more rounded shape, which can be a sign of cellular dysfunction. And the third key feature is the presence of newly formed blood vessels, the neovascularization, so which you can show here, which you can see here. And these new vessels are coming from the anterior side, from the fat pad, and they're growing into the anterior side of the tendon. Now the translation into clinical practice, because when I established a clinical diagnosis as a clinician, I would like to know what additional value would the imaging have. So can it visualize the abnormalities? Can it monitor treatment effect? Or can I provide a prognosis for the patient? These are important questions for us, and that's the reason why I started my thesis. First, I'd like to show you an image of a normal Achilles tendon. So we're looking from a side here. Here's the calcaneal bone insertion of the Achilles tendon. This is the mid-portion area, and here more proximal, the musculotendinous junction. This is a normal tendon, so it's really flat, and you can see the fiber alignment is normal. In case of pathology, you can see a tendon thickening, which is also present during physical examination. Another thing you can see is the power Doppler signal, which is increased. I will come back to that later. And also a decreased tendon structure. So in case of tendinopathy, we can see an increased power Doppler flow, which may be a sign of the neovascularization, which we can also see on the histopathological image. And we found in a cross-sectional study that there's a clear difference between asymptomatic tendons and symptomatic tendons. Also here we're looking from, we're looking from a side. So here we can see a normal flat tendon of an individual without symptoms, and there's no increased Doppler flow. And here again a sagittal view, and we can see an increased Doppler flow, which may be a sign of the neovascularization. Approximately 70% of the patients do have increased Doppler flow. We also performed a prospective follow-up study in 58 patients, and we followed them with power Doppler ultrasonography. And we found that there's no prognostic value of the Doppler flow. And I will show you in this figure where the vertical axis is the symptom score. The higher, the better for the patient, and on the horizontal axis, the time. With the continuous line, I displayed the patients with neovascularization at baseline, and with the dashed line, the patients without neovascularization. And as you can see, there are no significant differences between these patients groups. So the presence of neovascularization doesn't help me to provide a prognosis for the patient. So it's not of additional value for me in the clinical practice. Moving on to the other feature, the decreased tendon structure. So first, again, a difference between asymptomatic and symptomatic tendons. Again, a look from a side, calcaneal bone insertion here, and this is the midportion area. We can see a normal alignment of the tendon fibers, and in case of tendinopathy, we can see a tendon thickness, but also dark regions in there, which we call hypoechoic areas, and are a feature of decreased tendon structure. So there is some conflicting evidence about its role, the presence of hypoechoic areas and its size as a predictor of outcome. And the main problem is possibly because it is an operator-dependent technique. And for that reason, we developed a novel method, the ultrasonographic tissue characterization, or UTC, which was introduced in equine tendons. And with this technique, we were able to quantify the tendon tissue structure, and it was matched with histology. So from this part, it will be a bit more academic, so hold on, and I will try to explain it stepwise, this technique, and I will come back with some advices in daily clinical practice. So the UTC is based on the principle that one ultrasound beam will result in one reflection in case of intact collagen bundles, but in case of a damage to the collagen, there will be a scattering. So there will be a variation in the gray level. This is how it works in practice. So this is an ultrasound probe which will move from proximal to distal over the Achilles tendon, and at every 0.2 millimeter a transversal image is captured and stored on a computer, and afterwards a three-dimensional view is made like with CT scanning. I will show you a movie of the technique. So the ankle of the patient is clamped in a holding device, ensuring maximum dorsiflexion so that the transducer is perpendicular to the Achilles tendon. The transducer is moved with a small motor and with a constant speed to enable high quality of the images. So at every 0.2 millimeter, the transversal images are captured, and here you can see the screen on the computer. It's a little bit foggy, so sorry for that, but you can see the concept that, well, we can see the transversal views and that these are stored. And I will show you the result. So now you can see the tendon in 3 planes of view. Here the coronal, sagittal, and the transversal view. Here you can already see the borders of the Achilles tendon, and we can define the maximum anterior to posterior diameter. So now a quantification process can be started. We can define the gray level of 1 pixel in the thickest part of the tendon, and we can do the same for pixels in the 8 consecutive slices. And these gray values can be correlated. And we know from the equine studies that intact collagen bundles are represented as steady pixels with a constant high gray level. And in case of damaged collagen, we know there's a high variation in the gray level or a constant low gray level as a result of fluid accumulation. Well, based on these properties, a color-coded system was designed. And it's really easy. It's like a traffic light. Green and blue are representing organized tendon structure, and the red and black a disorganized tendon structure. So here we can see an image of a color-coded tendon. In the transversal view, the border has been shown here, and within the tendon you can see a lot of green and blue pixels representing organized tendon structure, and on the posteromedial side you can see some disorganized tendon structure. This is an example of a patient. We did not only define it in the maximum thickened part, but also we defined it in a volume of 3 centimeters in the mid-portion area. So first we did a cross-sectional study where we could find a significant difference between an asymptomatic tendon, again the transversal view, and within the tendon we almost only see green and blue pixels, so only organized tendon structure. And in case of tendinopathy, we can see an increased disorganized tendon structure, so increased red and black pixels. So after that, we performed a double-blind, placebo-controlled, randomized controlled trial in 54 patients. They all performed a heavy load eccentric exercise program consisting of 180 repetitions daily for 12 weeks, which is the current standard according to the national guidelines. And half of the patients were randomized to a placebo injection and the other half to a platelet-rich plasma injection, or PRP. And PRP is defined as a platelet concentration above baseline. It can be derived from the patient's whole blood. And we know that these platelets are able to secrete growth factors which can have a positive influence on tendon healing. So our aim was to decrease the symptoms, of course, and to regenerate the tendon tissue. So I'll show you the ultrasonographic results. I can already tell you the PRP didn't work better than placebo, so forget about that treatment. But it's all about the imaging now. And we were able to monitor the treatment effect. So this is a patient who received placebo injection. But as you can see, on the posteral medial side, a clear tendon structure disorganization, but already after 24 weeks, a significant decrease of that lesion. And you can quantify it and objectively follow it over time, which is really interesting. But if we look at the correlation with symptoms, we had 4 follow-up moments, so approximately 270 measurements, and we could correlate the symptoms. Again here, the higher the better for the patient, and on the horizontal axis the organized tendon structure degree, and the higher the better the organized tendon structure. And as you can see, there's absolutely no correlation, which is more or less similar to the osteoarthritis patients who also where also a discordance is present between the patient's reported pain and joint space narrowing. It's quite similar. We also looked at the prognostic value. So main question for me would be, can I predict whether this tendon, which doesn't look so bad, has a better prognosis than this tendon, where we can see a large amount of tendon tissue structure disorganization, and there seemed to be no prognostic value. So that was quite disappointing. If we also had an asymptomatic group, so a matched group, matched by age, gender, and activity level, and we compared that to this patient group. And if we look at the tendon structure organization, we saw before the start of treatment a significant difference between those groups. But as I already stated, there was a significant increase in tendon structure organization, and at 24 weeks there was no significant difference between the symptomatic and asymptomatic patients, or asymptomatic group. But at this time point, still 40% was symptomatic. So again, it emphasized the discordance between symptoms and tendon structure. So again, the take-home messages. Ultrasonography can depict abnormalities in chronic Achilles tendinopathy. It can visualize changes over time. However, there is no association between the abnormalities and pain, and there's no prognostic value of the ultrasonographic abnormalities. So it's quite disappointing on a musculoskeletal congress to tell you this, but I think it's relevant as well because it has its limitations. Still, I think it could be useful also for this condition because I can use it as an explanation for the patient. We can really objectify something that's wrong in the tendon, so it helps them to understand what is wrong and what they can do. It helps me when I'm uncertain about the clinical diagnosis or as a guidance for injection therapy. I thank you for the attention and I think some food for discussion.
Thank you very much, Robert Jan, for this presentation. Are there any questions from the audience?
Thank you for an excellent presentation. I would like to ask, what injection therapy do you personally use and advocate, and when would you do it? Can you repeat that?
Yeah. So as I understood you correctly, you're interested in what kind of injection therapy I would advocate. Well, I'm not so fond of injection therapy, so I don't use it very often. I think there are lots of other conservative measures we have to take before we think about injection therapy. But if that would fail, after a good clinical assessment and from the medical history, load management, and also the biomechanical analysis, if these measures would fail, sometimes you can think about an injection. And well, as I already stated, the PRP doesn't work, so I'm not fond of that as well. There are some studies about the effect of prolotherapy, which is a concentration of dextrose you can inject in the peritendinous space. So in that case, ultrasonography can be really helpful to exactly locate where you have to perform the injection. Another therapy also applied in the peritendinous space is the high volume injection. So up to 40 mL of C-line is injected in the peritendinous space with the aim to destroy the neovascularization. And there are some case series showing positive effects as well, and we are planning to start a study on that. So it might be interesting to follow it. Yeah.
And I saw you quoting Alfredson. What about polydocanol? What are your thoughts about polydocanol?
So the question is what my thoughts are of polydocanol. The polydocanol is a sclerosing agent which can help to destroy the neovessels. And it's mainly used in Scandinavia. And I know the study, there's also a study being done here at AMC which didn't show effect of it. So it could be a quite demanding technique. I performed it as well in the past, but it's really hard to localize exactly the neovessels and to perform an injection there. So it's really a demanding technique. That might be the cause that it's only showed some positive results in Sweden by Professor Alfredson. So I don't perform it in daily clinical practice. It could be helpful if you're really experienced in the technique. Yeah.
Any questions?
You said there is no prognostic feature about the midportion ultrasound, but how do you see it with exercise? Because what I do is when I see that the tendon is more organized, I can do a higher level of practice with the exercises. How do you see it to mentor that?
Sorry, I will repeat the question right after, but do you mean by exercises the activity level or the specific exercises like the Alfredson protocol with the eccentric drops?
The higher level of exercise.
The activity, yeah.
Explosive.
Yeah. So the question is, there's no prognostic value of the ultrasound, but you're using ultrasound in monitoring the patient during exercises, and it helps you to increase the load when the ultrasound image improves as well. Well, as I showed you, we also used this standardized ultrasound technique to monitor the treatment effect also during the exercises, and we didn't see the correlation between the ultrasonographic images and the patient-reported pain and activity level of the patient. So for me, it doesn't add up to perform ultrasound images of it, because in the end there's no correlation between the symptoms and the ultrasound. And I think in the end you would like to treat the symptoms and not the ultrasonographic picture. So for that reason, I wouldn't use it as a monitoring tool.
So what about the use of shockwave? What effect on the Achilles tendon?
Yeah. So question is what the use of shockwave could be in Achilles tendinopathy. I know from the shockwave it mainly works in insertional problems for the Achilles tendon. So there's some evidence to use it there, especially when there are calcifications in the tendon. It's also applied in the mid-portion Achilles tendinopathy, but there's some conflicting evidence. So there are multiple RCTs. Some show beneficial effects, but also a placebo-controlled trial didn't show any benefit. So it is something you can apply. I prefer it above injection therapy because it's less invasive. So if other measures would fail, it's one of my first treatment options.
In addition to the question, do you think there's differences in the pathologic mechanism of the mid-portion and the tendinopathy and the insertion tendinopathy in case in which, for example, your lateral tendinitis, you try needling, try to initiate response, healing response with neovascularization. So I think the same is for shockwave immunization generally. But I think with your story about the neovascularization has no complication and no additional value for your clinics. Do you think it's a different mechanism? And what's the value of neovascularization in mid-portion and then insertion tendinopathy? I think I myself, the insertion tendinopathy is necessary to initiate some neovascularization in order to start an initial response, a healing response. And with the mid-portion, we don't know what the reason is about for your neovascularization. So do you think there's a difference in the mechanism?
Yeah. Thanks for your question. I'll try to summarize it. Correct me if I'm wrong. But the main question is there a difference between mid-portion and insertional tendinopathy, and mainly regarding the neovascularization? Because it could be that neovascularization plays a different role in the mid-portion area than in the insertional area. Well, first of all, I think there really is a difference between the mid-portion and insertional area. In the insertion, there could be a bursitis as well, and there's mainly a compressive load on the Achilles tendon, so it's compressing against the calcaneal bone and sometimes the bursa, which is really another biomechanical problem. And we frequently see tendon abnormalities as well as and also the neovascularization. I don't think it's another process, because I think it's part of the degenerative process we see both in the insertional and the mid-portion area. And you're true that the dry needling, for example, is applied to induce new small lesions and to induce newly formed vessels. The same theory was behind the PRP injections, which also secrete VEGF, the growth factors that stimulate the neovascularization. So it's not really clear if it would be a good or a bad thing. But we also saw after the PRP injection an initial increase in neovascularization and a decrease afterwards. But again, no correlation with symptoms. So for me, it doesn't really add up at this moment. And there are some new imaging techniques developing, like the contrast-enhanced ultrasonography, which is a really interesting technique to quantify the neovascularization. And some researchers in Denmark already showed that they missed neovascularization on Doppler ultrasound, but they showed it on the contrast-enhanced ultrasound. So that could be an interesting area.
Tendinopathy might be presented with peritendinosis. Did you have a look at that in your study? Does it have influence on your prognostic and your pain factors?
Sorry, I didn't read. Peritendinosis.
Yes. Did you have a look at your research?
I don't know really how you would define pre-tendinosis.
Well, inflamed tissue around the tendon, which might be inflamed and it might be different than the
Exactly. Yeah. So
the anterior side.
you're meaning the peritendinopathy. So it's an inflammation of the sheath around the tendon or the peritendinum. So the main question is, did I look in my studies at the role of peritendinous abnormalities? Well, it's a very interesting question because I think that could play a role as well. But the hard thing is to visualize peritendinous changes. So there's one histopathological study that compared the histopathological examinations with ultrasound and MRI, and it seemed that the evaluation of the peritendinous space or the peritendinous abnormalities does not correlate with the histopathological images. So that's really the hardest part to examine with use of imaging. So I agree with you. It could be a limitation of our studies, so that patients could have pain because of peritendinous abnormalities, but you wouldn't be able to pick it up with imaging. Only in the acute ones, for example, when there's a lot of fluid in the peritendinous space, which is obvious, but in the chronic cases, it will be difficult. Yeah. Yeah.
You talked about change in tendon, which is not related to experience of pain and stimulation. Did you find any indication of anything that is related to pain which patients experience?
So question is, did I find anything that is related to pain? Yeah, it's a major question also for me now as a researcher. What is causing the pain? And I still don't have a real good answer to it. And we know that from a very large study that the neovascularization is weakly correlated with the pain. It could be that the accompanying sensible nerves are a cause of the pain there, but it's only a weak correlation. So I don't think it explains all of the pain in the patients. There are some new studies that showed some pain signaling neuropeptides in relation to tendinopathy. So there was a clear difference in histopathological examination between healthy individuals and patients with tendinopathy. They showed neuropeptides like glutamate, substance P, CRGP, which are neuropeptides that can cause pain and also cause structural abnormality. So there could be a link there. And also in the Erasmus Medical Centre, we're trying to focus our research on that part because that could play an important role in the new treatment options.
Do you have any experience with shear wave elastography in the field of tendinopathy?
I don't have personal experience with elastosonography, but I know that there are some studies out there that correlate that histological examination with elastosonography, and it's perfectly matched. So it is a validated technique, but I don't know any cohort studies that showed any additional value of it. But it's an interesting subject.
Yeah, it can
for
bring
sure.
something,
Yeah.
probably for the prognosis.
Yeah.
Okay, Robert Jan, thank you very much for your marvelous presentation.